Chitra gave me this topic because she wanted me to talk on the same lines, and but as is clear, I am in a AIOS ARC Leadership Development Program, a very privileged moment when you are with the future of AIOS leaders. I would rather see that what intangibles we don't see, and how we can actually try and work something forwards. So that would be my viewpoint. And as a leader, I think we all need to learn from our chairperson ARC, Chitra, how to be in it, actually, how to be in it. She's really in it, how we can be prepared to give, which is most important, and ready to receive. Because any giving act will reciprocate in the other person giving you back, but we need to process it and correct and move forwards. So essentially, I would see a leader as the lead strategist. He should be responsible for selecting his team, for designing a unique, workable model, and to take it forwards. And in all this, he is the person center. So he has to, strategy is all about making choices. So it is not that I can do this and I can do that also. It is about I will do this. So that focus is important. Now, as Dr. Rao was saying, how are we poised here? See, I mean, very different from the rest of the block. We are at a per capita which is much below 5,000 per annum, dollars per annum. Where is India with a CSR in the cataract surgical scenario? As close to developed countries like Japan, and there are many below, Canada, so many below us. And this is what great teachers, great mentors like Dr. Gunapalli Rao and their institutions have done to the Indian scenario. They have cascaded a total system of capacity building, renovated the entire game of eye care, and has made it into a simplistic model that even practitioners like me could latch on and could start thinking of having a hospital and taking it forwards. But having come here, focus on the last bottom line. For the last 3 years, the CSR in India is probably just the same. And if you say, oh, are we now going to go down or what's going to happen next? Well, no, I mean, as Dr. Rao said, there is a huge demographic backup. If we compare the 45 to 55s, the 55 to 65s, because these are the backup age groups which come up, the pyramid looks pretty okay for us. I mean, that way it is fine. And if we look at our institution, hospitals figures, then we probably stand as what more could we have done? Like almost a 60% with vision better than 612 at operation for cataract. Essentially, we have reasons to think now that probably we are not working at the total level. We are working in a very limited sphere of place. So let us explore this area and go forwards. If we see the, the industry gives us good figures. So I took these figures that what is the PMMA and hydrophilic lenses? That's about 50% of the total IOLs used. And then comes the second group where the per capita is between 8,000 to 24,000. And then comes the 10% group. So probably we are going around this 50% bracket, whereas this upper 50%, the 0 to 8,000 rupees per month income range group is something which eludes us. And as Dr. Rao said, it is for the government to take up, and it is for us also with the growing economy to see what is possible there. We have to explore. Now, let us compare another scenario, that this is the amount of anti-VEGFs being used in India. And this is the major, but I would rather focus on this 3,50,000 figure. Whereas if you see any developing country, and this is only 1/20th of the total cataract surgical volume. Whereas if you see any Western world stats, it is 1 to 2 times of cataract surgery. So we should be giving 65 lakh anti-VEGF. How far are we back in this? Okay, AMD considered the 3 regime recommendations of ETDRS. Let us treat PRN. But still too, it has to be at least half of cataract, at least 10 times more than what we are doing today. How do we go there? I mean, if you see the cataract statistics of Disha, which is a totally paying hospital doing 70,000 surgeries, this is the profile which also substantiates the slides that I showed. Now, having said that, there is an intervention ratio to various procedures, and this is across the 12 lakh patients that we see annually. This is the intervention ratio. I mean, to 1 retina injections, we see 115 patients. So essentially, at a 612, 6/9 cataract vision at operation, the injections being 1/20th, whereas we need to times. I think what is most important is that we need to focus on comprehensive care, and that too, there are the problems of this wide territory, the economy, and the cost. Just imagine if we just take the retina injection. If we subsidize this 300 rupees, 30,000 rupees would be to just find out a case which would benefit from injections in this distribution. But this is not the scenario. At economies of scale example, I'll give one of this, that doctors don't want to do indirect ophthalmoscopies. So we bought this Optos machine and put it in hospital which sees 500 patients. So at 30 patients a day, at just rupees 300, we could recover the cost of the machine in 3 years. And it diagnosed peripheral lesions better, there was better compliance, and the patients actually got lasered. And now we have 6 of these Optos equipments around us. So is the laminar flow care, which also economically becomes so viable. So all this, we can really think of. So essentially, from a private sector point of view, we often ask this question, the big question, what does the patient want? We have to provide everything. But the patient wants everything, that's the problem. So a better question probably would be that what is the patient willing to pay for? And that is the start point, that is the real need, that is the felt need. And that from there we have to come to the real need. So it is from aspiration to affordability. And we have explored from our little data points that it is probably 1 days per capita in the OPD, 1 month per capita for a cataract surgery, and 3 months, which is equivalent to 3 months of the square feet cost of the residential area, some equative standards. And another thing I would always say, that the staff can afford the average cost of cataract surgery, but that is the affordability level we need to focus on and work on. So fair price is a very important thing, and we need to fair price our surgeries properly. transparency, and this package brings faith and creates aspiration and leads to better compliance and a better word of mouth publicity and propels growth. And probably, social marketing improves a unique value chain system which can actually propagate forwards, and we can carry an organization to replicate and to perpetuate, which is most important. So location is very important. It has to be a growing elderly population with young, vibrant economy, expandable, visible, accessible. Underserved or fringe areas are important. Retiring practices or joining some practices are other options. Having said that, we spend our preparatory years, but then as an organization, it resembles a life of a human being. I mean, as the child years from 0 to 5, it is to a surgery center with, 1,000 to 2,000 square feet, small practices, which contribute and form the major part of the private sector offering to eye care. And then as we hit these critical numbers are important because we are working on a very shoestring thing, and we have to price our products very affordably. So we cannot have sleeping costs, and we have to have the best capacity utilization, do maximum with little. So everything matters: the recruitment, marketing, growth, collaborations at every stage, group practices, innovations, outreach, which Dr. Rao said was so important. And then, as you grow, you can have a mix and match of surgery centers, vision centers in the rural or semi-rural areas, diagnostic centers, so to say, in the city, and have a mix of all of them. And at the 30 years beyond, we also need to think not that an institution, goes down the order. So phasing out, passing the baton, and perpetuity should start focusing on an organization like ours with me on the chair at this point of time. So this is our growth of OPD patients. This is how the branches came up, giving a small example of these 4 yellow points, which when we first entered the city, we created 4 centers in the 4 corners of the city. And finally, we also went around a little we followed our following. Wherever we saw there are 50 patients, 100 patients coming from a district town with a radius of around 100 patients per day in a radius of 100 kilometers, we started a capacity hospital of 300 to 400, and very soon it would be utilized. And these 4 centers we now accumulated into our new town facility, which is kind of a dream for us. So this has been our growth curve of cataract, retina injections, and retina surgeries. So this is, you can just have a snapshot look at it. So growth has been an important propellant in this. And these are the revenues when the last year was COVID. So you can well see a revenue dip of 20%. I think all the staff and the doctors did amply well in these difficult times, and we could sail through majorly without much of an hiccup. Now coming to the main point where we were talking, this is one equipment. This is a photograph from one equipment, and these are the quality of photographs and the OCT and the angle OCT and the pachymetry and the anterior OCT and the angle OCT. So it has everything. Now this equipment is probably, can be bargained down to 15 lakhs. If you, and I am sure, I mean, if we go further on, and if everybody, what I'm trying to say, let vision centers have it. I mean, if we are talking of, Chitra had been talking about the issues of technician diagnosing maybe an angle closure or a diabetic retinopathy. But when you have this, you can definitely understand that this patient has diabetic retinopathy. All our technicians understand that. And then it can be forwarded. Telemedicine for prescriptions are obviously fine. If we can have this, this is the next stage that I'm trying to focus on. I mean, let us have vision centers with this one device, and it could be the most useful teleconsultation. So this is a thought which I leave you with. And well, cost is more important than quality, at least in our circumstances. And I definitely consider him as a very wise person, but quality is the best way to reduce costs. And obviously, when we are in a so technical world, simplification of technology so that the intangibles become tangible is something that we always look forward. Thank you very much for your attention. Thank you very much.
Thank you, Dr. Debasish. That was a very practical talk which you shared with us. Can you hear me?
Yes, I can.
No, because suddenly my screen has gone. I would want comments from Dr. Ramurthy and Dr. Avinash. I think I need to get connected again. Dr. Ramurthy, are you there?
Yeah, I'm very much here.
Yeah, I think you and Dr. Avinash have to get connected again. Not able to see all.
Your picture is coming, but
We are able to see him, madam. Ramurthy sir, go ahead, sir.
All of you.
I can't see.
Lovely talk, Debasish, and very practical. Nothing less was expected of you. You know, this apart from talking about general aspects, you also have to give some messages to the attendees. One of the things which struck me about your practice is that, you know, it's not a very high-end practice. It's not the extreme, the top end that you are targeting. At the same time, you're not doing any free service. You know, it's the middle level you are been catering to, and you have been extremely successful with that. This is not the model that most of us have. You know, we have people who are at the top end catering to the people with the highest of paying capacities. Then you have institutions who mid-level as well as the community ophthalmology practice. How did this idea come to you? And you know, this is also a mass practice, and you have been able to build upon it. And what is your advice to youngsters who might want to follow your footsteps?
No, essentially, as I said, first we need to have a very proper understanding of the location. In fact, you know, the choice of location also matters in a big way. Because any health eye care service depends upon its proximity. I mean, people cannot come for far off places unless it is an absolute tertiary care facility. So the location definitely guides, but I think pricing is very important. And essentially, if we follow the growth of our OPD, the interventions that we require, I mean, how many interventions are we doing for a patient? How many patients are we seeing? How many cataracts are we doing? What is our compliance? If we follow that, we can price our services better. And so essentially it would be to get as many people in. So affordable pricing, fair pricing is a basic requirement, and some risk taking around that is also probably justified. That maybe, you know, if we, you might say, you know, that it's undercutting. You know, another private practitioner may feel that it's undercutting, but it's not really that. Because it is generally, you have to follow systems. You know none of the consultants are big names. So they are basically skilled and trained well to perform at a good level. So that is the quality that an average eye care seeker looks forward to. And if we can attend that, I think there is scope. So we should. But more importantly, I think there is more scope in the base of the pyramid, especially around comprehensive care, because the other things over this 30-35 years, the cataract ballgame, I think is, you know, how far can you go? and you're operating 6-9 cataracts. I mean, where can you take it from here?
Dr. Avinash, a brief comment. I think we are running short of time.
No, it's just a question which I wanted to ask both Dr. Rao and Dr. Bhattacharya, in terms of, because when we interact with a lot of youngsters, one of the naive questions they ask is, Doctor, since they are so much involved in learning ophthalmology or even various subspecialties, how do you know that I have become a leader? So there's a question for both of you. Like,
Dr. Rao, are you there?
Yeah.
Yes, doctor, we want from you.
I don't know if there is a very easy answer. The one thing that I think as an indicator that you are a leader is, for me, that if I have the discipline, and then I have certain habits that inspire others, small ones. It doesn't have to be a big inspiration. And then others begin to follow you, and you see others doing the things that you are doing and imitating. Then I know that person is a leader. The person who has instilled that kind of confidence in others through self-discipline, through their systems, and inspire others to follow them, you can see that there is a leader there coming up. And also the other thing that we do as you know, Avinash, is in our system, we give them an opportunity to run a small section of the institute and see how they do. That's the second stage.
Absolutely.
And that's in effect a pilot project on their leadership skills. And that's how we have always built our pipeline of leaders. And we've done fairly well.
Yes, you have, doctor.
Definitely you have.
Yeah.
Yeah, I would say that, the moment Avinash, a youngster, has a dream, and that dream is keeping him awake, and then you understand and you start talking, then that youngster will start talking. He will start talking with his friends. Some, because he keeps on talking about it, will become his foes, will, move away from him. And if that dream, which, he starts enacting it, so he lives that dream every day. So it is, that is why dreams are so important. And when the opportunity comes, the opportunity will definitely come. We say that, ophthalmology is getting tough, everything is getting so competitive. But no, I would say even a penny beggar on the street has a better day. So he will or she will get an opportunity, and how you latch on to the opportunity will depend of how intensely you have dreamt of that moment, so that you take the moment forwards. And obviously, as Dr. Rao said, these virtues are most important. Sacrifice is a very simple word. To give is so simple. And when you give, you automatically become a leader, and things will follow. It will keep on coming, because if you give, the returns will definitely come back. So obviously, time's up. So,
Dr. Srinivas, you have anything to say?
I have a question to Debasish sir.
Yeah.
Debasish sir,
Yes.
you have been a costing guru, right? I saw where you people operate at around 18,000 rupees for an IQ or a Technis lens. And I was told that you were asking for the Femto PI interface, cone interface at 8,000 rupees, when it was available in the market at 23,000 rupees. So as Ramurthy sir rightly asked the question, so you are onto low cost and the high value kind of practice. How is it even possible for everyone to replicate? Second question, you don't have...
You can't ask two questions. We don't have time.
So last one, madam. You don't have DNB or fellowship programs as of now, as I understand. But still you have enormous centers and you have a very good human resource in ophthalmology. It has become very difficult to get a good ophthalmologist nowadays in the peripheral centers. How have you been able to tap up these young minds?
So to take your first question first, we had DNBs. Now we rely on fellowships only, because being a paying hospital only, we cannot use patient resources to, teach people, which is LV Prasad is that is why LV Prasad is LV Prasad. So we can't take patients' money to teach people. So we teach people only whom we absorb as consultants. So that is a recruitment mechanism. But DNB was previously, but since they started that you can, we cannot choose our DNBs. I mean, DNBs will come through the entrance, and so then we left DNBs. So, and regarding this urban and rural thing, the youngsters actually goes 3 days in the rural area, in the semi-urban district towns, and 4 days they enjoy city life. We give an outstation allowance, and of course, happy patients are everybody's goal, but if we must have happy doctors to give happy patients. So we keep them happy.
Thank you. Thank you very much.
Thank you so much.
May I answer one question that was raised? Is that okay?
Ma'am, actually, we're running out of time.
Okay. Just to answer that question for the youngsters on how do you identify yourself as a leader? One question, the minute you start thinking, the minute you start raising questions, and the minute you start reassessing what your leaders have done and finding your own ways, I think we start getting to fit into the role of a leader.
Great.
And I'm talking in the midst of
No.
leaders, but this is how I would look at ourselves and the youngsters, that the minute you start thinking, you are becoming a leader.